the poster that was presented at the Endocrine Society meeting recently in San Francisco was about the 24 or I guess 28 week, 6-month and 12-month data from the Crinecerfont trial. So just to kind of review a couple points. So, children with CAH have a high prevalence of obesity. And so do adults with CAH, which then puts them at risk for cardiovascular disease as adults. Secondary to adrenal crises, the second most common cause of death in adults with CAH is cardiovascular disease. So they have a lot of metabolic risk, and it develops in childhood because of the exposure to the high doses of glucocorticoids that has traditionally been necessary to manage the condition adequately. And so the intention of the Catalyst trial was to show that adding Crinecerfont, which is a CRF type 1 receptor antagonist, can lower the adrenal androgens and allow use of lower, more physiologic doses of glucocorticoid. And the question that this poster was addressing is, does that reduction in glucocorticoid dosing translate into improvements in weight and body mass index parameters? So, in the trial, almost 60% of the children in the pediatric trial were overweight or obese. So that's pretty high, and that's pretty typical of CAH populations. And their average body mass index was about 1.1, 1.2 standard deviations above normal. So during the first 6 months, where there was a randomized, double-blind, placebo-controlled 2-to-1 assignment to either the Crinecerfont group or the placebo group, the androstenedione came down by about 50% in the Crinecerfont group, which allowed their glucocorticoid dose to be reduced by about 18%, whereas it actually went up in the placebo arm. Okay, so then what happened to body mass index? Well, it dropped, not surprisingly, in the Crinecerfont group after the end of that period, whereas it actually went up a little bit in the placebo arm. Now, a year later, at that 28-week point, the placebo arm was crossed over into Crinecerfont. And from other data that was presented at the conference, that actually allowed the placebo arm to have an experience, a reduction in their androstenedione values and 17-hydroxyprogesterone values, which allowed their glucocorticoid dose to then be reduced. And then body mass index went down in the placebo group after they were switched to Crinecerfont and had the glucocorticoid. Now, interestingly, at 12 months, the improvement in body mass index was greater in the people who got Crinecerfont initially. And so I think what that tells us, even though the statistics are marginal, that, the longer that you delay this reduction of glucocorticoid, the longer you keep them on these high doses, the harder it is for them to compensate for that later on. So I think the intriguing thing about this poster is the imperative of trying to reduce the glucocorticoid dose as low as possible, as early as possible in children, to set them up for better metabolic parameters as they go into adulthood. The general pediatrician will see these patients, and they're going to be concerned about this. And there is something that can be done about this now, which we didn't have years ago. And so I think there has been a tendency, when you don't have an alternative, to just say, oh, you're doing okay. Oh, this is not that much extra hydrocortisone. It's going to be all right. But I think what we've learned is that even these small reductions in glucocorticoid dose do make a difference in terms of body weight and insulin sensitivity, as it turns out. We saw the parallel thing happen in the adult study, that people lost weight and their insulin sensitivity improved when we dropped their hydrocortisone dose. It was only like from 30 milligrams a day to 20 milligrams a day. But, any excess is an excess. It's like radiation. There's no safe exposure. So I think that lends credence to this idea that that even modest excesses of glucocorticoids are not good for you in the long run. Sure, for a couple weeks, a couple months, no problem. But for for decades, as these people are getting, that's not a good thing.